take Stimulation for a cholesterol?
So, yeah, that's a question that comes up often. And even among the neuromuscular physicians, we have battles about whether this is something that needs to be done or that should be allowable to somebody with a muscle disease or not. In general, I don't think there's any evidence that somebody with muscle disease is predisposed to that side effect of the statin drugs, the cholesterol-lowering drugs. But obviously, they have to be more careful. I would suggest that your physician check your muscle enzyme before you start taking it and monitor that carefully. At any sign that your muscle enzyme is going up, that's a CK measure in the blood, then they have to kind of take you off of it. But again, it's a balance between if you really need that medication, then you should probably take it, but be monitored very carefully.
Thank you.
I have two questions. Can you over-exercise, marathon, pump a lot of iron? Would that be detrimental? Do they know? And where would you find a surgeon? And is it a very big operation to have the mouth surgery done?
No, these are kind of minor surgeries, and again, you have to do it. I think you have to put the surgeon in the context of what you have, and that's where your neurologist may be helpful in talking to the physician about what exactly it is, because most of the surgeons are probably not used to doing it on somebody who has FSH.
What type of surgeon would do that?
Probably a plastic surgeon or a faciocranial surgeon. Your question about, yes, you can overdo it just like anybody else. So just be sensible. If you're doing too much and it hurts, you're doing too much. Yeah.
Yes. In the same here?
Yeah.
And what about the use of muscle relaxant? A lot of with pain, sometimes we use it. I'm a little concerned of my muscles. I feel when I'm overtired and it's hard to sleep, I take some kind of muscle relaxant, and the next day I don't have pain, but my muscles are weaker or flabby. What are your thoughts about that?
Yeah, I mean, muscle relaxants are, almost all of them are sedating to a certain extent, and some people are very sensitive to them. They do work, but and it could be part of a treatment for chronic pain. But again, you have to probably reduce the dose to make it and sometimes it takes a few days, a week to get used to a dose.
Hi. I know that I had my genetic testing, like it was like probably 10 or 15 years ago, so the differentiation between type 1, type 2 didn't really exist then. It sounds like the mechanism of the disease, type 1, type 2, is really different, so I'm wondering, as therapies are being developed, will there be different therapies depending on the type? And is it important for those of us that have had genetic testing to actually get typed and more specific?
Yeah.
So about the mechanism, it's the same. It's just another way of having the DUX4 gene active. So it's DUX4, which is Joker, the toxic protein that destroys the muscle. So it's a different way. So in FSHD1, it's changing the copy number of D4Z4, and in FSHD2 is destroying an enzyme, a protein that is involved in making compact chromatin. So the two result in having open chromatin, and if the DUX4 gene is there with the 4QA, so with the end of the DUX4 gene, then you produce the DUX4 protein, which is toxic for your muscle. So a priori, the drugs that are directed against DUX4, which are developed as a therapy for FSHD1, they will work as well for FSHD2. Well, it's important to get typed, because for all the research that's going on, and to see how the disease is progressing in somebody who has FSHD1 versus somebody who has FSHD2, it's important to know exactly what is the genetic problem. But as far as the drugs being developed are concerned, there should be no problem.
Hi, I have a question about kyphosis versus lordosis. I've seen many more people here affected with lordosis, and I'm just the opposite. I'm kyphotic. Do you have any suggestions or proposals for me of exercises I should be doing to perhaps increase my ability to stand up straight, short of putting a rod on my spine?
Yeah, I mean, most of individuals with FSH, lumbar lordosis, is the bigger problem, but some do get your back muscles get weak up on top, and if that's the major problem, then you're going to get kyphosis. I mean, I don't have a quick fix for that. I mean, I think you have to talk to a physical therapist, probably see an orthopedic surgeon also, a back surgeon, and to look and see how bad the scoliosis is, the kyphosis is, and if it's something that can be fixed surgically. But I would do that carefully, considering, again, talk to your neurologist about that to make sure that that's not something that is going to make things worse.
Thank you very much for your excellent presentations, both of you. Number one, does FSH affect swallowing? And number two, is there any time when it is associated with chronic skin itching?
The skin itching, no. The swallowing is, I think, rarely. I mean, most people will have problems manipulating food because of weakness of the cheeks and the tongue sometimes. Actual swallowing difficulty back down here, very rare.
Where do we go to join the registry? I'm sorry if I missed that. And what's your favorite type of cookie?
No, the registry, that's what you mean.
So there are forms outside that have information about the registry, and you can access it online.
Strawberry cookies with a lot of whipped cream.
A quick question about stimulants. So taking a very low dosage of Vyvanse does wonders for my ability to focus and write, if that's what I want to do, but I was a little reluctant as to whether that would be contraindicated in any way. And I know I had a pulmonologist who said, oh, it's best not to take anything, and a cardiologist who said, well, there's really no reason not to. So, not sure.
And so you're taking just...
I'm not taking, I have a prescription. I took it for a while. It really helped me focus, which is kind of ADD related, and but I just wonder whether it's something that I should not be doing.
So, I mean, the reason I'm asking is because if you feel kind of tired and sleepy, that sometimes suggests pulmonary involvement. But you have a pulmonologist, and that's not an issue.
It did give me more energy. I found
Right.
myself a lot more energetic with a little bit of Vyvanse in my system, and I didn't experience any negative side effects.
But your lung function is okay.
No, I do have some restrictive. I found out since. Yeah.
But so yeah, I mean, I think I'd be careful about that and make sure that the sleepiness, the tiredness, is not related to sleep disordered breathing when you lie down.
Hi, over on this side. Quick question, for when we get to the point, if we fast forward and we can stop the expression of DUX4, what does it look like as far as muscle regeneration? I know I'm asking probably to speculate a little bit, but can we build back the muscle? Does it just depend on how damaged it is, or can you speculate a little bit on that?
We'll share that. So I think, yes, it does. One, we don't know right now. But I think if there is a drug that's capable of regenerating muscles, there are muscles that may be beyond that point. If there's a muscle that's very weak and it's mostly fibrotic, not likely to regenerate, it may stop progression, but it will not make it better. But it depends on how effective the drug is.
Yes, I think the point now for those people who are developing what they hope will become drugs for FSHD is that the drug will stop disease progression by preventing DUX4 from being produced or from being toxic. So there are different strategies are being developed. And then the next question is, okay, we stop destroying muscle, but will muscle be able to regenerate? And normally what is wonderful in our muscles is that we have special stem cells which are associated with the muscles and which remain silent for many, many years until we get muscle injury. And the injury will wake up those stem cells which are not far from the injury site, and they will start dividing to produce muscle cells that will fuse with what is left of the muscle and help to regenerate. Now, the big question we have in FSHD is that we are not sure that those stem cells can be waken up. And we probably will not know that until we come to the point of giving a drug to stop disease progression and then see what happens. But as Dr. Tawil was saying, there are for various other muscle disorders, people who are developing drugs that help reconstruct muscle mass. And this could most probably help in FSHD if there is no spontaneous regeneration.
Okay. Can an international patient sign up for the registry you mentioned?
Where are you?
Right here.
It's always the sound always comes from here. I think the way the registry was started, it was NIH funded, so they restricted it to the U.S. We've kind of smuggled in some Canadian patients, but that's about it.
Okay. Yeah, because
but I mean, there are registries across the world, many registries around the world.
do you know if there is one in South America? Because my brother lives in Venezuela, where there are a few resources.
I don't
right now.
Jeff, do you remember on the list? I don't think we saw. Yeah.
Hi, I'm registered in São Paulo, Brazil, with Dr. Mayana Zatz.
Oh, yeah.
In terms of the registry, I'm not too sure what you meant by genetically confirmed. Is there something that an FSH individual or the parents of an FSH individual can do to see that they are genetically confirmed?
If you've had, I mean, what I mean by that is that you've had DNA testing that confirms the diagnosis. Do you know, or some patients don't know. I mean, sometimes I think we are not very good at getting back to the patient sometimes and telling them this is what we've done. So and I think we've seen that in the registry. A lot of them telling us when they filled their questionnaire that they didn't get tested, but indeed when we get their medical records, they have been tested.
You talked about DNA testing, and we see stuff on the TV all the time about genetic testing. I've been blood tested for FSH, and I assume that I have FSH1, but I have not gotten any documentation from my geneticist that states FSH1. Now, if we volunteer for the registry, do we send in another sample or get another sample tested by your geneticist?
No. If it's been done and we can get the records, I mean, you have the right to get those results, so you can ask for it. But if you will sign a release for your medical information that comes to us, and I review all of the records, and if it's there, you don't need to have it tested again.
And probably it was not mentioned FSHD1 because at the time FSHD2 was not known. So it was, they said FSHD, that's it. But it was FSHD1 at the time because FSHD2 was not known.
2 years ago.
Oh, then FSHD2 was known.
All right, I'm over here to your
Oh.
left. I have seen reports about translocation between chromosome 4 and 10 in some FSH patients, and I was just curious kind of what the field knew or understood about how that might change the genetic mechanism and if there's any functional consequences of that.
Yeah. Okay, so the repeated elements on chromosome 4, they can also be found on chromosome 10. But up to now, it's not there. You know, the repeated unit contains the DUX4 gene, but you have to have an end, which is outside of the repeated elements, and which is found on chromosome 4 Q A. So this part is not present on chromosome 10. So if you have chromatin opening on chromosome 10, you will not make a stable DUX4 messenger RNA, and you will not produce the toxic protein. It's only on chromosome 4 if you have the 4qa allele that gives the end to chromosome to the DUX4 gene. Some people have rearrangements between chromosome 10 and 4. That means chromosome 10 breaks, chromosome 4 breaks, and they exchange a little bit of DNA, so that you end up having mixed repeated elements, so on both chromosome 10 and 4. So what matters is just whether somewhere, either on chromosome 10 rearranged or on chromosome 4 rearranged, do you have a full DUX4 gene with the end. If you have that with the end, and it's open chromatin, you will develop FSHD. If you do not have a DUX4 gene with the end, then it's no problem. So it's more complicated for the geneticists who are trying to define exactly what is the defect in a patient if there was a rearrangement between chromosome 4 and 10. But on the basic mechanism, it all comes down to the joker. Do we produce the joker? Yes, if we have the DUX4 gene with the end. No, if we don't have the end.
Good. Right here.
Dr. Tawil, I was one of those Canadians that snuck into your registry. I'm also registered with the Canadian registry. I'm just wondering if you could list out for attendees here that are not Americans, which countries do have registries, and could you also answer as a researcher what coordination efforts are being made between the registries globally? Thank you.
Jeff, do you have? Yeah.
I think we can probably make a list of the registries available for people after the conference, right? Yeah, and so I think that we could do that, and I'll let Rabi speak to whether the harmonization.
Yeah, so there's a registry in the UK, there's a registry in France, there's a registry in Italy, in Holland, in some of the Eastern in Belgium. Yep. So these are the major ones. There's some other smaller ones. So there has been, there's an organization called Treat NMD that's based in Europe, and they harmonized, they set basically a minimal data set that has to be in an FSH registry. And so, and most of the registries do abide by that, but some registries are minimal, just kind of listing somebody with their DNA testing and that's it. Our registry is more detailed because it has a lot of clinical information that we can use to kind of mine and learn about what happens to somebody with FSH over time. There's been talk about making a global registry, but it's complicated because of issues of confidentiality of medical information, how you share the information. It's complicated. We've talked about it for many years, and we've managed to have a common data set, but that's about it. It's not going to be combined at this point, but it may at some point.
Right here. Go ahead, you go first.
Oh, don't fight.
I should go? Oh, okay. I want to find out, is there a treatment path with reducing or stopping hypomethylation? And if so, are other diseases where this is an issue, if they have advancements, will that benefit us?
So that's a very interesting question, and scientists have tried. There's some chemical that you can take in food that was thought of as being a way to help methylation. I know there was a trial many years ago that was done by the people in the Netherlands, but it did not show any improvement. So it's not clear. But this is a very smart, it would be a very smart strategy to be able to do that. So there are now other approaches, but it's still at the level of research in the laboratory. But some people are trying to do that.
My question is about patients, family members of patients who test positive. How certain are we that they would ever develop symptoms of the disease? Do some people have the genotype without the phenotype? Do we know anything about that?
Yes. So these are the patients with the small contraction of, so they have on the upper end of the copy number of repeats, so between 8 and 10. And so these are the individuals that are likely not to have what we call non-penetrant. So they're carrying the gene, but they're not going to show it. And so, yeah, I mean, so in general,
ready to take a break in about 3 minutes.
When somebody gets diagnosed, oftentimes what happens is that they want to test their kids. This is something that we discourage because there's no sense in learning that and let them live their life until they have problems. And if they're adults and they're still not showing signs and they want to decide to get tested, then that's what should be done. Did that answer your question? Or?
What's the likelihood that those people will ever go on to clinical presentation? Do we know that? We have observational information?
No, it's difficult to know because, I mean, it may be that they can present at the age of 70 with their first symptom. So you'd have to follow them over a long period of time.
Hi. Looking ahead again, is there such a thing, or could there be such a thing as harvesting cells, turning them into muscle stem cells, modifying them with something like CRISPR, and then creating muscle tissue, reintroducing them into patients? And if so, is anybody working on something along those lines?
So there are researchers indeed working in this idea. So taking stem cells and trying to graft them into muscle to help rebuild the muscle. This is something that has been tried in other diseases. And even there was a small trial in FSHD in France many years ago. But it's very difficult because you take stem cells. If you take the cells from the individual itself, so let's say you have the arms affected, but not yet the legs. So you would take a chunk of muscle from the leg, take the stem cells from that chunk of muscle, and grow them in culture in the laboratory, and then graft them in the arms. Well, that's the assay that was done in France. But it did not work. Why? Because the cells in your legs have the same genetic information as the cells in your arms. So they have the DUX4 gene. Maybe it's not active yet, but it is there to be activated. So that would not work. Other possibility is to take the cells and correct the genetic defect, as you were saying with CRISPR-Cas9, which is another way of saying a pair of scissors, to cut the piece of DNA that is wrong and then glue back the two ends of DNA. And there are some people who are doing research in that direction, but it's not done yet. But that's a possibility, at least in theory. So I think 40 miles from here, and in the Netherlands also. Yeah. So the group of Peter Jones, I think, is working on that also. And maybe also in Minnesota, they are doing things of the kind.
I think so, yeah. So
I'll ask the last question because we're almost at the time for our break. But a big development in my mind was the creation of an ICD-10 code specific for FSHD. Could you tell people why that's important and what action we might take, you know, for patients starting in the fall when this ICD-10 code comes online, I guess?
I think you asked the wrong person about that. So ICD-9 code allows you know the medical community to actually and individuals with FSH to be represented. And it's all in the coding. You know, now there's a specific code for FSH muscular dystrophy, and so data about the general population about who has FSH muscular dystrophy can be accessed and looked at and studied.
But it's important in terms of starting to create a way for public health data to actually, so right now you may not realize that if you get a diagnosis of FSHD at your doctor's, someone looking at the big picture of the prevalence, how much FSHD has been diagnosed in the US, would not be able to extract that information from our public health data because it's not coded. So if you've had a diagnosis and next time you see your doctor, tell them it can now be coded specifically for FSHD because you can have the code, but if the doctors aren't using it, it's not going to help either.
So the CDC is already working on looking at the prevalence of FSH, as they've done with DMD.
Yeah. Okay. Oh, one more question, and then, or all of a sudden, their arms going up over.
Hi, June. I wanted to know, do you know what the code is yet? Do we have that information?
We'll have to check it on our website in a few weeks. But yeah, just keep your eyes out for it.
I mean, it should come up when your physician will put in the electronic data record, FSH muscular dystrophy comes up. I don't know what the number is.
Okay. Hi, I'm Natalie Street. I'm actually from the CDC, so I might be able to answer this question pretty well. I don't know the exact code offhand, but we do have that information. That code is set to go in effect October 1st of 2018. But what we can do with that is we can actually look at different data sets and find that code in different like healthcare data sets and study things like what's the clinical course of disease, what's the prevalence, and different things that we couldn't do before because we couldn't specifically say who had FSHD because the code just that we had before just it was included other types of muscular dystrophy within that. So I think that's going to be a pretty powerful research tool, but we're going to be able to start looking at that, I think, starting in October.